Very good morning. In today's class, we are going to discuss about endo-perio lesions. So, coming on to endo-perio lesion, they both have an embryonic and a functional and anatomic relationship. This relationship is causing your endo-perio lesion. And we have a mixed anaerobic bacteria which is involved in both the pulpal and the periodontal infections. So that is why we have most commonly encountered combined lesions in our day-to-day practice. So combined endoperio lesions are estimated to cause 50% of tooth mortality. So coming on to the pathways of communications. I have already told you that both pulp and the periodontium are interconnected. They are communicating through these three pathways. First is the anatomic pathway, second is the pathologic pathway, and third is the iatrogenic pathway. In anatomic pathway, we have apical foramina, patent dentinal tubules, and lateral and accessory canals. In pathologic communication, we have external and internal resorption, developmental grooves. In iatrogenic pathway of communication, we have perforations, over instrumentation, and vertical root fracture. Apart from these communications, in endoperioral lesions, we have something called as contributing factors and etiologic factors. The contributing factors are poor endodontic treatment, coronal leakage, trauma, root resorption, perforations, development malformations, cracked tooth syndrome. All these will contribute to the contributing factors. Coming on to the etiological factors, you have both living and non-living. In living, you have bacteria, fungi, and viruses. Under these, we have anaerobic bacteria, facultative anaerobes, rare anaerobes, aerobes, and Candida albicans, herpes simplex, HCV, and EBV. Coming on to the non-living pathogens, we have foreign bodies, dental and cementum chips, amalgam, root canal filling materials, cellulose fibers, absorbent paper points, which have been used during your treatment procedures, and gingival retraction cords, leguminous food, and calculus-like deposits. In extrinsic and intrinsic agents, we have all these things. And in the intrinsic agents, we have cholesterol, Rushton hyaline bodies, results bodies, and Charcot-Leyden crystals. It is like endothelial lesions will be having both contributing factors and etiological factors. In etiological factors, we have living, non-living. In non-living, we have extrinsic and intrinsic agents. Okay. Now coming on to few classification. We are just going to discuss about two classifications over here. First is the most commonly used Simon et al. Classification, wherein endoperio lesions are classified as primary endo, primary perio, and combined lesions. In combined lesions, you have primary perio, secondary endo, secondary perio, and true combined lesions. Coming on to Torabinajad et al. Classification, you have six types of lesions. First is endodontic origin, lesions having endodontic origin, lesions having periodontic origin, combined endo and perio lesion, separate endodontic and periodontic lesions, lesion with communication, and lesion without communication. So, just two of the classifications I have addressed. And now coming on to the investigations. Most commonly, in investigation, in how to come to a diagnosis, you will conclude with your diagnosis based on the history taking, examination, and that periodontal examination, radiographic evaluation, pulp testing, and fistula trial. Coming on to the visual examination, in soft tissue examination, you will find out inflammations, ulcerations, sinus tracts, etc. In hard tissue, there are chances of a caries, teeth, or defective restoration, cracks, which is fractures of the tooth, and discolorations. And on palpation, you might feel a peculiar periradicular abnormality, and on percussion, there may be periradicular inflammation leading to pain. Coming on to mobility, whenever there is mobility, it is evident that there is loss of periodontal support. And most commonly in those states, you will be having associated periradicular abscesses, and there are chances of fractured root. And coming on to probing, uh, whenever you're probing, if there is a deep solitary pocket, it is high chances of a endocause, that is an endodontic origin lesionite endeavor. Or else, if it is due to a periodontic reason, the periodontal pocket will be broad and deep enough. This is and in fistula tracking, we often use 25 GP to assess the fistula. In fistula tracking, we will just insert the GP and take a RVG or IFA. Over here, you can see the GP is inserted until you feel a resistance, and an RVG or IFA is taken, wherein we can track the fistula to that concerned tooth. So, and another investigation is pulp testing. In electric pulp testing, whenever there is a primary periodontal lesion, the response may be positive. And if it is a primary periodontal and secondary endodontic lesion, you might have a mixed response. And in primary endodontic lesion also, you might have a mixed response, wherein in primary endo, secondary periodontal and combined pulpal and periodontal lesions, you will always have negative response. And false positive response may be interpreted in combined lesion in multi-rooted teeth. Okay, it is common to come across. And coming on to the characteristics which you should be checking in your patient's subjective symptoms, coronal integrity, radiographic appearance, vitality of teeth, and periodontal probing. So in it is just this tabular column is just in total of what will be the patient symptom, what all the coronal integrity, radiographic lesion, vitality, and periodontal probing of these four conditions. Commonly, I have taken primary pulpal, primary periodontal, independent endodontic and periodontic lesions, and combined endodontic and periodontic lesions. So over here in this tabular column, you can see that in primary pulpal lesions, the patient's symptom might vary. The patient might even have uh, mild to moderate or even severe discomfort. And coronal integrity is always compromised in pulpal immobility. And it is PARL. PARL is periapical. Sorry, it is periapical. 1 minute. Let me go to the previous slide. Yes, periapical radiolucency. Okay, PAR stands for periapical radiolucency. In primary pulpal lesions, you have periapical radiolucency, and the tooth is often non-vital. And during periodontal probing, you might have a narrow periodontal pocket. And in primary periodontal lesions, the patient might have mild discomfort, and the coronal integrity is often intact with a mild crystal bone loss on radiographic evaluation. And there are high chances that the tooth is often vital and there is generalized bone loss. And during periodontal probing, as I have told you, it will be a broader and a deeper periodontal pocket. In independent endodontic or periodontic lesions, the patient's symptom will vary and the coronal integrity is compromised. There can be a separate periapical radiolucency and a crustal lesion. Tooth is often non-vital and there is generalized bone loss. And in combined endodontic and periodontic lesions, the patient's symptom will vary. Compromised coronal integrity is there and continuous bone lesion from alveolar crest to the apex can be seen in a combined lesion. Okay. And non-vital teeth is present and generalized bone loss with narrow probing to the apex. So these are the parameters which can be seen. And coming on to this treatment plan, actually you might be seeing a very big, what to say, 1 minute. You can be, you can see this many classifications, a decision tree as such, okay? So in primary endo, what is the significance? In primary perio, what is the significance? 1 minute, my slide is changing. Okay. In endoperio lesion, whenever there is a primary endo lesion, you always start with endodontic therapy and then you will reevaluate the patient. If it is a primary perio lesion, you will always do periodontal therapy and reevaluate the patient. Now coming on to primary perio and secondary endo and primary endo or secondary perio. As a general rule of thumb, whenever you are treating a primary one case and secondary one case, you will always address first the primary endo lesion. Okay, so primary endo, you will start whether it is a primary perio or secondary endo or primary perio or secondary endo. You start with primary endo, then you will go for reevaluation and perio treatment. Okay, this is in total. I am just telling. Even if it is a combined lesion, you can always start with endo treatment first. Primary first, it is endo treatment, then followed by a perio treatment. And then you will evaluate the patient for 2 to 3 months. If there is full resolution and mobility is open, if there is a bit of mobility, you can go for splinting and then again reevaluate the patient for every 3 months. It is 3 months, 6 months, and 12 months. And if there is no resolution, if it is a hopeless prognosis, please proceed with extraction and we need not wait. You can explain the prognosis to the patient. And if there is no resolution, if it is a multi-rooted teeth and resective therapy like root resection can be opted and even bicuspidization or hemisection and even apicoectomy can also be done. So all these things, whatever may be the case, whatever may be the treatment which you have done, re-evaluation is always mandatory. You should re-evaluate the patient once in every 3 months. So coming on to the prognosis of a tooth will depend on patient's oral hygiene, the amount of attachment loss, endodontic status, effectiveness of the periodontal treatment accomplished. That is, if it is primary endo, most commonly we can expect a good to excellent prognosis. If it is a primary perio lesion, it depends on the response to the periodontal therapy. And in combined lesion, most commonly we can see poor prognosis of the tooth. So this is what I have already told you. Whenever you are evaluating, if there is no resolution, you can go for hopeless prognosis, extraction, hemisection or root resection if it is okay, multi-rooted teeth, and then apicectomy, apicoectomy, and then re-evaluation after 3 months. Okay, even if you are doing splinting, you should re-evaluate. Okay. So with this, we are completing our class as such, and thank you for your attention.